Varicocelectomy or treatment of significant varicoceles which are symptomatic or which are troublesome to an individual male is an important aspect of care which we need to probably take it to the society. There are multiple reasons for this awareness drive about varicoceles for young men. So let's take those important salient points as to why we're discussing varicocele care and what does varicocele mean. The two testes which hang in the scrotum in men who don't have cryptorchidism, that means both the testes are in the scrotum, are actually having a blood supply which come through the arteries and go through the veins. The arteries could be single as testicular artery, but the veins which take away the blood from the testes are a bunch of veins which are called as pampiniform plexus. So there are plexus of veins, few of them are closer to testes, and then gradually they coalesce together to make single veins as they enter the retroperitoneum going up. So when we look at the pampiniform plexus, when you look at the veins getting lesser and smaller and probably taking away the blood back to the testis, it is known that the dilatation and tortuosity of these veins can happen as a result of progression in various aspects of testicular changes. It is known that when testis actually enlarged as a result of puberty and thereafter the growth, the testis drags down, and the aspects of valve, the aspects of mechanisms, and the aspects of various changes which happen in a growing testis, the veins could become dilated and tortuous because there are multiple of them at the level of scrotum. This dilatation and tortuosity of the veins is called varicocele. It is different from varicose veins of the leg, which is treated by a vascular surgeon. The varicocele is actually like hydrocele, which is collection of fluid in the scrotum, which as a urologist, we do a treatment and remove the fluid. Varicocele is basically the tortuosity of the veins only. So the veins, which when become tortuous and dilated, and then when looks at these changes around, you actually would be able to feel them as veins palpable around. So when they are significant, a patient could describe saying that my palpation of the scrotum feels like a bag of worms, which means an advanced and a progress and grossly dilated and tortuous veins, which is visible to me on an examination as the urologist when a patient is standing down. So varicocele could be having a hindrance in the testicular changes around, and that's what we need to look into. There are two aspects which we need to understand. One is a subclinical varicocele, many a times picked up on sonography, and a patient comes with a report around. We clinically examined this young man in his 20s, 30s, 40s. This was done for testicular pain or for discomfort in the scrotum and the inguinal region, and incidentally detected varicocele in an individual. That's one aspect which we need to look into. There could be men who could be having scrotal or testicular pain, and that pain is also an important aspect to identify because you want to evaluate the cause of pain. Orchalgia or pain in the testis is unfortunately a very common phenomenon. Many men suffer with very different kind of pains, which could be very idiopathic, not necessarily always organic or cause related, from the region of high sensitivity, which is the testis and the scrotum and the groin, and they come with orchalgia and the neuralgia of the kind which we treat. Now, when we look at a man complaining of pain in the testis, pain in the scrotum on one side or both sides, an examination is the most important aspect. A urologist would examine him both in lying down and in standing posture. He will look at that. Normally, the varicocele would actually disappear from the standing to a lying down posture because it can be drained back as the patient lies down. But they could be quite significant when the patient stands, and therefore, the complaint of the patient could be that I have difficulty and discomfort in my scrotum in the evenings, in late evenings, and when I'm returning back from a long day's work, in a standing job, or when you're standing for a long time. This kind of a discomfort and testis is clinically correlated and corroborated with changes which are happening in the scrotal examination. The cords could feel more capacious, and therefore there's more capacity, more stuff palpable inside, which actually becomes softer and drains out when the patient lies down, and therefore the examination in a standing and a lying down posture, starting with standing posture, number one. Number two, many times the varicocele may not drain, and it could be a non-draining varicocele, which means that the drainage mechanisms are getting obstructed somewhere upwards in the renal vein or the IVC, and one needs to look at the causes by doing a sonography up there. The evaluation of such patients is a lot by scoring, a lot by identifying, a lot by examination. We need to understand that how long has it been there, how much of difficulty and how much of discomfort around. So the varicoceles are treated always surgically. In other words, if you're looking at gold standard and treatment of care, then it should be surgically ligated in the most minimally invasive possible, so that we are going to bring about a therapy and a care to a cure of a condition which we need to look at. So when does varicocele require cure is in two conditions. Number one, when there is testicular atrophy and testicular size gradually going down, number one. And this happens perhaps because the varicocele could be too large and it could actually engulf the entire testis, bringing about a toxic effect both by the warmth, by the toxins, and the testis is known to gradually atrophy ipsilaterally, sometimes also contralaterally on the opposite side. So large varicoceles which are significant bag of worms, grade 3-4 varicoceles can actually affect the testis, number one. So if that is happening in young men, who could be even 18, 20, 25, 30, who are still not married or married recently and still to father children, reversibility can be brought about by tying the varicoceles or knotting or ligating the varicoceles by a minimally invasive surgical technique. That's one. Number two, primary infertility, where we're not able to conceive because of male factor infertility, where we identify that there is oligoasthenoteratozoospermia. That means there are changes in the spermatozoal counts and various morphological changes happening around as a result of significant varicoceles, more so on the left or bilaterally. These patients would be subjected to varicocele ligation by, again, a minimally invasive technique at the Coquelin Bain Hospital, which would help them from getting sorted out. So testicular getting small and softer and worsening with time, number one side or both sides in terms of shortening as a result of a large varicocele. Number two, patients who are for a primary infertility or a secondary infertility where varicocele has actually moved in, created a kind of a change which is affecting the spermatozoal production and its maturation. And thirdly, ipsilateral or contralateral or bilateral testicular pain, where the significant varicocele could be a reason for pain. By a very careful and good evaluation by urologists, are indications for varicocelectomy. There are no major other indications where we need to do a varicocelectomy. Some reason you look into, one more reason could be patients with severe oligoteratozoospermia who have got even a minimal grade of varicocele, where the only aspect of treatment apart from various combination and empirical therapies could be a varicocelectomy, because that would look significant, bilateral, and is not changed with time, could actually bring about some changes, as also has been done for the azoospermia group. But we're concentrating on significant clinical varicoceles, where we should not be doing varicocelectomy for subclinical varicoceles picked up on a sonography. Many times patients do come to me and say, I underwent a varicocele surgery after 2 years and 5 years ago. And now I've got, after varicocele surgery, still the pain is there. The pain has worsened. The new pain has come back after surgery, many months or years after surgery, or a new onset pain. So has the varicocele recurred, or has there been a neuralgia which has developed, which is actually worsening an individual, needs to be picked up. So at the Coquelin Bain Ambani Hospital, the kind of andrology work in the men's health we look into, young men's health on varicocele is a very important aspect of care, which is quite missed out, which is quite missing in the public domain, I must say. And that missing aspect has to be looked into. That look which we are trying to give to this subject is only because many a times the patient may undergo various therapies of embolizations and surgeries which may cause huge degree of recurrence. Patient may continue to still have a lot of discomfort. The primary endpoints have not met, that is discomfort, pain has not gone. His testis continues to atrophy. His varicoceles are still there, which have the record of which probably have not got completely treated. So the state of art varicocelectomy today at the Coquelin Bain Ambani Hospital that we practice is called microscopic subinguinal varicocelectomy with a very small subinguinal incision, which later on is closed by subcuticular stitches on one or both sides, which is just below the lower level of the tummy in the region of the groin, near the region of your inguinal fold, with a small incision. We hook up the entire cord contents, identify them, and then with the microscope, which is multiple times magnifying the entire aspect, identify these veins. Now, don't forget that the veins and the lymphatics may look similar. And therefore, microscopic varicocelectomy aided by intraoperative doppler is a state-of-art technique that we practice at Coquelin Bain Hospital, which is a state-of-art technique across the world, which means that we are attempting to ligate only the veins, which sometimes the lymphatics may confuse us to, and obviously want to prevent the arteries from getting ligated. So state-of-art technique for doing a varicocelectomy as a subinguinal varicocelectomy with a very minimally invasive approach with a centimeter, 1.5 centimeter incision, which is closed down internally. After a microscope is got in around, the intraoperative Doppler with a probe that helps us to identify the various waveforms by the sound that is created from turbulence which happens in the varicocele, in the lymphatics, and in the artery. Gives us 3 different sound waves and makes us identify that this is an artery. We safeguard it. The vas is palpable and safeguarded. And thereafter, the lymphatics and veins are segregated. There's no need to tie lymphatics. A lot of lymphatics being there as a result of edema, as a result of changes, tied could only cause more amount of a secondary hydrocele and edema in the cord, which is not required. So a state-of-art subinguinal microscopic varicocelectomy in the groin fold on one or both sides as clinically indicated for a patient who has got symptomatic varicocele, which is either causing an infertility, not improving with various fertility measures adopted. Number 1. Number 2, has got pain and discomfort in the groin, basically in the scrotum, which is to be treated around. Many surgeries done in the past with recurrence of varicocele or as such orchalgia or testicular pain happening in individuals is another entity altogether. Individuals may continue to have testicular pain or orchalgia and pain in the region of the groin, for which various therapies have been done, including surgeries at time, and they have either worsened or they have never improved. So they like quite, disorganized and disgusted with their quality of life, where pain has become erratic, comes in the region of the thighs, groin, scrotum, penile organs, and one needs to look into them, improving their quality, giving them the care and the cure where they deserve, with a lot of medical management, identifying the various neurobiological agents and giving them the relief, which could sometimes be long-term, which could be an escalation and a de-escalation regimen, as we induce them into a program of therapy, where we look at preventing pain rather than treating pain alone, and look at not getting a flare-up on these phenomena. Many patients who have continued orchalgia or pain in the testes not resolving around are therefore treated conservatively and not always by a varicocele surgery, which sometimes is done for very small varicoceles, which could be done maybe unknowingly or maybe done because of the patient would require a surgery as he thinks upon or the clinician thinks upon. Therefore, a very judicious approach of varicocelectomy is an important aspect of care which needs to go to society and to clinicians as to which varicocele to touch, which not to touch. Look at the 7 parameters as a very important parameter. Look at the discomfort of the patient with large varicoceles as a very important parameter. So varicocele or dilatation or tortuosity of the veins in the pampiniform plexus is a male phenomena, more commonly on the left than the right. It could be bilateral. It could lead to infertility. It could lead to discomfort in the testis, in the groin. It could look at a dragging pain. And these kind of aspects can be treated and cured, not necessarily by medicines, but by a surgery called varicocelectomy. Look forward to a very minimally invasive, very successful microscopic subinguinal varicocelectomy by a subinguinal technique, aided by intraoperative doppler at the Cochlear Vein Hospital and Department of Urology on the 2nd floor, to help many and many patients to be getting well and getting cured of the dreams that they require to probably fulfill as a result of changes which have happened progressively and gradually in very prime of life. Thank you so much.